topics and opinions expressed in the following show are solely those of the host and their guests and not those of W4CY Radio, its employees, or affiliates. We make no recommendations or endorsements for radio show programs, services, or products mentioned on air or on our web. No liability, explicit or implied, shall be extended to W4CY Radio or its employees or affiliates. Any questions or comments should be directed to those show hosts. Thank you for choosing W4CY Radio.
Welcome to the Ask the Expert show on W4CY Radio and Talk4 TV, where we bring you educational information from top local experts in the fields of legal, health, financial, and home improvement. Now sit back and listen to experts in family law, association law, hearing loss, business brokers, home care, along with many other topics. Now here are your hosts, Steve-O and Sophia.
Hey, good afternoon, Houston. Welcome to another Ask the Expert show where we bring you the top experts in the field of legal, health, financial, and home improvement. I'm your host, Steve-O. Hey, we are doing our great Houston show today. Though I live in Florida now, Houston is my second home. I lived in Houston for a long time. I love the people in Houston, the Houston area. Hey, today is probably like one of my favorite shows. And the reason why is I suffer, well, I guess I don't suffer anymore because I'm been treated, but I suffer from sleep apnea. And I know what it feels like to suffer from sleep apnea. And we got so many letters from listeners saying, how come you don't do a stop snoring or a sleep disorder show? To be honest with you, we had no room. We were completely, everything had been filled, and we all of a sudden got an opening. And I said, I have got to find somebody who really specializes in sleep apnea. I got to tell you, I am so blessed. We found one of the greatest clinics in the city of Houston. And I'm going to tell you something. If you're outside the Houston area, Conroe, Huntsville, I'm telling you, you want to, if you've got a sleep apnea problem, you want to come see Dr. James Ludwig of Sugarland ENT and Sleep Center. Good afternoon, Dr. Ludwig.
Hey, Steve, how are you?
I am so, I can't even explain how happy I am that I've got this show now and I have it in Houston and that we found you, that because you're one of the top experts, and I mean experts in the field of sleep apnea. And you know, you also do ENT also, but just the way you explain everything. And what we're going to do is all those people sitting around today who might have sleep apnea, we're going to educate you for the next 50 minutes. Dr. Ludwig, tell people about your practice, first of all.
I've been in practice for 20 years, pretty much. We're located now in Southwest Sugarland, right at University in 59. I'm a solo practitioner. I've always been a solo practitioner after I worked at Baylor as a faculty when I first graduated, but since then I've been a solo practitioner. And I did a fellowship in sleep medicine, which is very unique. I'm the only ENT in at least the Southern United States, if not the United States, that did a fellowship in sleep medicine. There are other ENTs that are board certified in sleep medicine, but they did that by being grandfathered in to be able to even sit for the board exam. And they didn't complete a fellowship. They just took a multiple choice test and they were able to pass it, which, you know, doctors are good at taking multiple choice tests. That's how we get our degree. So it really allowed me to learn a lot about obstructive sleep apnea. I trained at the VA with one of the most well-known sleep, he's a PhD, but in the community of sleep, Max Hershowitz. And I train right next, alongside with pulmonologists. So it's really helpful for me, even though I'm an ear, nose, and throat doctor, because a lot of patients that come see me are new diagnosis of sleep apnea, or they're on air pressure devices and they need help with management, which honestly, as an ENT, we're not well trained at all during residency on that type of treatment. We're mainly trained on nasal surgery and palate surgery and tonsil surgery for sleep and breathing, but we really have very little hands-on experience in managing people on air pressure machines, or understanding why they can't use them, or helping them use them or be successful. So and then so I dispense CPAP machines. I've done it for 20 years. I do sleep surgeries. Of course, we do nasal sinus surgeries. It all kind of goes together. And then we also dispense fit oral appliances when I think they're indicated to treat sleep apnea. So we pretty much do every treatment for sleep apnea except for what oral surgeons do, which is maxillomandibular advancement. And that's such a small percentage, 0.01% of patients will undergo that type of a procedure to try to correct their sleep apnea. So we pretty much treat 99% of patients that have the problem. We have the ability to treat, I should say, and use all of those different modalities, or one of them or two of them, or whatever the patient needs to help them get treated. So
I tell you what I love about your practice. You have many choices for your patient to choose from. If I went to a dentist, he would always have an appliance. That's it. Yeah, if I go to some of these other clinics, it's CPAP only. But you give a patient many choices.
yeah, I think even more important than choices is really understanding how all those treatments work together, because sometimes you need more than one treatment, or sometimes you need to put them together. Just like sometimes you have high blood pressure and the doctor starts you off on one medication, and then your blood pressure doesn't respond that well, and he raises the dose a little bit, and then it's still not where they want it. They'll add a different medication that works a different mechanism to work together with the first medication. Same thing with diabetes, same thing with depression, same thing with, honestly, most conditions, that sometimes one modality isn't going to cut it. And I think also just understanding how those other modalities work, you're able to help patients, troubleshoot, incorporate those kinds of things. And if you just treat one disease one way, and even though you may have heard of the other ways, or you went to a class or a weekend, seminar, you really don't work with patients with those other treatments. You can't understand, maybe why they're failing. Because sometimes people come to me wanting an alternative to, say, air pressure, because they can't use air pressure, but really they're okay using air pressure if they could use it. They just can't use it. And it's if we can figure that out, then sometimes they end up just using air pressure, even though the reason they came to me was to not use it. It just depends on what their real motivation is. If you feel like you can't use something, then you're certainly, in your suffering, you're going to look for another option. But what if the reason you can't use something is maybe because you're just not helped properly, or someone missed something, that's complicating your ability to use that treatment.
Right before the show, we got a text from, they saw we are going to be doing a show on sleep apnea today, and he wanted me to ask you, if you snore, does that mean you have sleep apnea?
It means you could have sleep apnea. Snoring is a noise it's caused from having a lot of resistance to flow when you're unconscious. So when you're not awake, people who do snore are not walking around while they're awake snoring. Okay, so
right.
that means objectively, right, something's different about their airway when they're asleep, because otherwise we would just be snoring 24 hours a day. Oh, even if someone who snores lays down flat and they're wide awake, they don't snore, right? So it's not just the position, it's the relaxation of the airway that creates, in some people, creates a lot of airway resistance. And so what happens is that because we still need the same amount of air per breath to live, we compensate for that increased resistance by pulling harder to get that air in the same amount of time. And that high velocity airflow creates lift, just like the same reason that planes can fly, right? Because wings on planes make air travel over the top of the wing faster than under the wing, and that creates lift. So that's why we snore, because we pull harder, we create lift in our throat area, and that our throat's made of soft tissues, and so those tissues vibrate. And that's the sound. You can snore because you're breathing through your nose. You can snore because you're breathing through your mouth, because your nose and your mouth eventually go to the same airway before it goes to your lungs, right? So, this, I snore with my nose or I snore with my mouth. It's not about that. It's about resistance. So, if you have a lot of nasal resistance and your mouth is closed, that may cause you to snore. And then if you open your mouth, you may not snore, and vice versa. So, yeah, snoring is just a noise, but it is a warning sign. It's like smoke. If you might have a fire, you might not have a fire. And then you combine snoring with, if you're overweight or you feel bad, you're tired during the day, or your sleep is restless, or you have medical problems like diabetes or high blood pressure, or you've had a stroke or a heart attack. And then if you have those other things, then it makes it even more suspicious that you actually have sleep apnea instead of just snoring.
So if doesn't mean if a person snores that they necessarily have sleep apnea.
Right.
What brings a patient into your clinic who thinks they might have sleep apnea? Why do they think that?
Well, they think it because someone told them they think they have it, like a friend, they go camping and their friend's like, Jesus, you're like dying in the tent next to us, or your wife or husband, not to be biased, it is, or maybe you have a procedure like a colonoscopy or esophagoscopy, or you go to have a tooth pulled and you're sedated by the oral surgeon. And then when you're sedated, they observe you having airway problems, those people. So, and some people kind of just know because they've heard about it through through TV commercial, they've heard of sleep apnea, and then they teach themselves about it by Googling and watching videos, and they realize that hey, that's me. So they come in for that reason, So some people, they're made to come in by loved ones, and some people come in because I think they've known for a long time that they've had the problem. Honestly, they just, like we all reach our breaking point. So
I know mine was snoring, but it was also during the day falling asleep.
yeah,
I fell asleep in a class. I started to fall asleep when I was driving, but I thought I slept for 8 or 9 hours.
Yeah, and you probably had sleep apnea for 10 years before you got diagnosed, and that's
good. Yes,
very, very typical, because it's not like one day you have sleep apnea and one day you don't. It's like in any other insidious disease, like aging or blood pressure. It's not like one day you wake up with high blood pressure and the day before you had normal blood pressure. I mean, for most of us, it's something that, one day you're normal weight, one day you're morbidly obese. It doesn't work that way. So, and sleep apnea is the same, it's the same problem. It's an insidious disease that you learn to cope with, at least unbeknownst to you, you're coping with it until it reaches a breaking point.
Brad from Clearview wants to know, what is sleep apnea? And that was going to be my first real question, was what is obstructive sleep apnea? So what is sleep apnea?
Yeah, it's when at least obstructive sleep apnea is when you're unconscious, your airway is getting too small for you to get enough air per breath. For the technical definitions, at least 10 seconds at a time, but the bottom line is you're not getting enough air while you're sleeping, because when your airway is relaxing, because our muscles relax when we sleep, and your airway is a muscle. By airway, I mean your throat. And so it gets so narrow that you're not able to get enough air. So, if you don't fix that problem, eventually you won't wake up, because if you don't breathe, you'll die, right?
Right.
I don't know if you ever learned CPR, but the CPR, they teach you A, B, C. A is airway, which means make sure the airway doesn't have something obstructing it. B is breathing, which is start giving them breaths. And C is chest compressions. But without an airway, B and C don't matter. So that's the problem, is you don't have an airway. And the way that we naturally restore our airway when we're having obstructive events is we have arousals. And I don't mean arousals like you wake up and have a conversation. I mean arousals like 2, 3, 4 seconds. No different than if you were sleeping and someone put a pillow on your face and try to kill you. You're not going to just die. You're going to wake up eventually and freak out. and try to fight that person off your face. Whether you win or lose, that's a different question, but you're not going to sleep through it. And just like the pillow on your face, if your own body's tissues are collapsing or obstructing your airway, eventually you're going to break out, you're going to come out of your sleep state, even if at a subconscious level, to restore the tone of muscles, to restore the patency of your airway. So if you do it one time, that's one event. One event, let's say one time you do it all night long. That's not sleep apnea syndrome. That's a sleep apnea event. Kind of like if you had an EKG done and you had one irregular heartbeat all day long. Okay, so that one irregular heartbeat shouldn't be there, but nobody treats you for that. You're not going to be on a pacemaker. You're not going to be put on drugs, But at some point, if you have enough irregular heartbeats where it gives you symptoms or causes a risk of heart attack or stroke, then we treat that, right? Like AFib or other arrhythmias. So sleep apnea is the same way. That's why I see a lot of people get miscommunicated. They get a sleep study done, and the doctor says, "Oh, you don't have sleep apnea." And then, the patient's like, "Okay, well, I don't feel good and I snore." But if you actually read the sleep study report, it may say something like, "Oh, we observed 30 airway obstructions in 8 hours. We observed you for 8 hours and we counted 30 times that you had this phenomenon." Okay. So, and they report the results as an average. And so in 8 hours, if you did 30, and of course, give myself a terrible math problem, it's about 4 per hour. But the clinical definition of significant is 5 per hour. Okay. So if you have less than 4 per hour, the doctor's going to tell you you don't have sleep apnea. But what he really is trying to say is you don't have sleep apnea syndrome through the arbitrary definition of what it means to have sleep apnea syndrome. And to take it to the extreme is, so in an 8-hour night, you're supposed to have 40 events. If you have 40 obstructions, and then you release those obstructions 40 times in one 8-hour recording, then you have what's accepted as sleep apnea syndrome. But what if you had 39? Or what if you had 38? So does that mean you don't have it because you missed it by 2? So and you have to go to extremes to get my point. So the point is that what I tell patients is, you have sleep apnea events. You're just not having enough for insurance to pay for treatment. It could be that those 30 events, albeit mild, okay, in severity, or actually by the definition, not even clinically significant, are significant for you. Because if you wake up 30 times a night, that may bother you, even though it may not bother someone else. Some people need 9 hours of sleep to feel good. Some people need 5 hours of sleep to feel good. Right? Who's to say not everyone needs 8 or 7 hours of sleep? It's just an average. So I get that a lot. I get patients come in with negative sleep studies, but still have complaints. And then, no one's helping you when they tell you your test is negative or you're still snoring and you still feel bad. So it could be bothering you. It's worth looking into.
Dr. Ludwig, what happens if a person didn't treat their sleep apnea? Does it get worse?
They feel like shit, like you do, if it's bad enough. Excuse my language, but it depends how bad you are. So untreated sleep apnea is known to raise your risk of heart attack and stroke, just like smoking or uncontrolled blood pressure. Things like diabetes that's not well managed. But it's just like any other condition, there's different severities. So the acceptable definition of, or how we define severity, is the number of times in an hour on average that somebody does this phenomenon. And 5 to 15 is mild, and 5 to 14 is mild. 15 to 30 is moderate. Over 30 is severe, right? Per hour, not per night, per hour. So you can imagine the more you do it, the more it's going to impact your health, right? Think about it. If you're doing this 30 times an hour and you're in bed 7 hours, that's 200 times plus, right? That you're having interruptions. How can you feel good if you're, interrupted in your sleep, unbeknownst to you, 200 times in one night? No wonder you feel like crap, So the long-term consequence is premature heart failure. Severe case, you get right-sided heart failure. It's called cor pulmonale. It's real severe guys get that. I have some patients have 80, 90 per hour, if you can believe it, 80 or 90 per hour.
Wow.
Not per night, per hour. Can you imagine they live like that? They don't even, I mean, think about it. They're 50 years old. They come in, they got 90 events an hour. They've been doing that for a decade. It's crazy.
Do they normally have high blood pressure too?
Oh, yeah, they all have high blood pressure. Yeah, they all look tired. You just look at them. They look like older than they are. You know, you just see it. And what's cool is when you treat them, they come back, they look younger than they were. I mean, because they're sleep deprived. That's the bottom line. When you're not treated for sleep apnea, you're by definition sleep deprived. Literally. You're sleep deprived. Every day of your life.
We are getting all kinds of questions in. This is Bert in Sugarland. That's where you are. Wants to know, what is the difference between a CPAP machine and a BiPAP machine?
Yeah, they're the same thing. It's just, it's more of like an R end, how we can control it. It's air pressure. It's just a different way it's a different way for us to program. Like I know you have a bi-level. BiPAP is actually a trade name from Philips Respironics. It's really bi-level. And one is continuous. They're both continuous. Just one, you can control the pressure when the patient breathes in. That's continuous. You don't really control the pressure on the way out. And then a bi-level, you can control the pressure on the way in and out. The box looks the same.
You just said Philips. Somebody just wrote in, isn't Philips in a lawsuit right now?
I mean, Philips has
with
a
their
recall.
CPAP machine.
Yeah, they had a recall.
A recall, okay.
Yeah.
So if they're on a Philips, I mean, do they need to contact Philips?
Yeah, I mean, pretty much they had millions over the last decade. All their machines got recalled because of the insulation they used.
Wow.
That's been going on since COVID. I mean, that's a 4-year-old problem. They still can't sell a CPAP machine.
Wow. Okay.
Yeah.
I guess I want to try to understand the difference in snoring and sleep apnea.
What do you mean?
Well,
what don't you understand?
Just because a person snores doesn't mean they have sleep apnea.
Right, because snoring means you're moving air, right?
Yes.
The question is, are you moving enough air? So if you make a noise and you move enough air, you don't have sleep apnea. If you make a noise and you don't move enough air, you have sleep apnea. At least you have sleep apnea events.
Okay.
Yeah.
And then if you have severe sleep apnea, say versus mild,
yeah,
that shows up on that sleep test that you do, that overnight sleep test, right?
Yeah, it's just the severity is defined by how low your oxygen goes and how frequently you're having these obstructions. I mean, the numbers are fairly arbitrary because, like I told you, at 30 per hour, you would have by definition severe sleep apnea. Okay, but what do you call the guy that has a 90 per hour? I mean, we don't have anything. We don't have a super severe. You know, we don't have like outrageous sleep apnea, right? It's just mild, moderate, severe. So I don't get you focused on the nomenclature. Like I said, and it'll blow your mind. You'll have patients with really a lot of disease, a lot of events, and they will actually effectively treat it with, say, a CPAP machine. And then they'll claim that they don't feel much different. It's not common, but I see it. And it's very weird. It's a very unusual. And then I have patients who are having that very mild version, and they treat it successfully with whatever it is. And you'd think you cured them of cancer, they feel so good. So that's what I'm trying to tell you. People's perception of how they feel and this disease they're suffering from, they don't always go hand in hand, as you would logically think.
What determines if you put a patient on the appliance versus the CPAP machine? Is it up to the patient?
A lot of time is money. So it's money. Because appliances in general cost quite a bit more than a machine, believe it or not. And I tell patients all the time, I mean, well, first of all, I do an exam. I mean, my practice, I try to determine who would benefit from an appliance. And the way that we determine that is by examining what the airway does when your jaw is in the forward position, because that's what oral appliances do. They bring your jaw forward. They hold it forward. Or at a minimum, they keep it from falling back if you happen to open your mouth and, sleep like this. If you do that, then they keep your jaw from falling back, or more commonly, we use it to push the jaw forward. And your airway, most people's airway will improve, the space will improve when their jaw is forward. Okay? So we'll examine the airway with a camera, and I'll have the patient bring their jaw forward so we can see together if they get a significant improvement in the airway. And if so, then we know at least when they're asleep, because I've done the exam asleep and awake on many other patients, that benefit of more space when you're awake, it translates into more space when they're asleep. Okay? Now the question is that more space enough to actually eliminate or dramatically decrease the number of sleep apnea events? That's the problem. You can't guarantee it. So this is what people have to choose a lot of the time. It's the guaranteed benefit versus the potential benefit. Okay, so if someone were to someone who has diagnosis of sleep apnea, let's just pretend, for the sake of argument, that I believe an oral appliance would be beneficial. By beneficial, I don't mean cure, I mean beneficial. Okay, but I know if that patient sleeps all night long with a CPAP device, there's a 95% chance they'll have little to no obstructions, like 1 an hour, 2 an hour, 3 an hour. Pretty much guaranteed, okay? So you're the consumer, you've got your credit card or checkbook, and I'm giving you your choices. And the one choice is this machine, if you wear it, 95% chance solves your problem while you wear it, okay? That's choice number one. Choice number two is, we both see that your airway is a lot better with your jaw forward. This appliance that I have, which costs double what the CPAP machine is going to cost you.
Wow.
And I can't guarantee you the exact benefit you're going to get. I think you're going to get a benefit. I don't know the exact number. So you have to be willing to risk the fact that you may not get as much benefit as you want. Okay? But most people, 95% of patients, will wear a night guard all night long. But 95% of patients will not wear a CPAP machine all night long every night of their life. Okay? Remember, these are treatments, not cures. So most consumers gravitate towards the word guarantee, and they spend their money on the machine, but they can't guarantee is they'll wear it. Like, here, I got this diet, Steve. I got this diet. I guarantee if you follow my diet, you'll lose 100 pounds. Guarantee it. But you know what you don't do? Follow the damn diet, okay?
Right.
Right. And so do you want to spend double the money on something you're definitely going to follow, which will probably give you a significant benefit, but maybe not as much as you want, maybe? Or do you want to spend half as much, but guarantee it's going to work? And a lot of people want the guarantee. So honestly, for a lot of patients, treating sleep apnea is a journey. It's not like you go and I have a wart or a mole on my back, and I go to the dermatologist and he freezes or cuts it off, and away you go. That's why surgeons go into surgery. Okay, we like to do passive treatment. We want to come in, fix it, remove it, cut it out, whatever, and then not see you again. That's honestly surgeries. Okay, that's the surgeon mentality. A medicine mentality is, I want to build a relationship with you over your whole lifetime and coach you along. And the frustrating part of that is not that doctors, including myself, don't like to coach people along. It's that many people won't do what you coach them. So they keep coming back smoking their cigarettes. They keep coming back eating the crappy food. They keep coming back and their hemoglobin A1C is through the roof, because you can only tell them what to do. You can't sit there all day and make them do what they need to do to get their medical problem resolved. But surgeons, it's like, oh, my septum is bent. Let me make it straight for you. Cut, boom, you're done. Now it's straight. Have a good day. So that's one of the most fundamental differences between a surgeon and a non-surgeon. We all care about patients, but we like to have the feeling that we're fixing something and now we're done. So a lot of what I do is non-surgical. So a lot of what I do is management. And So that's why I say sleep's a journey, because even people like you, Steve, that maybe you have a CPAP machine and you use it for 5 or 10 years. Sometimes after 5 or 10 years, you're like, you know what? I sleep well with this thing. I don't want to have to use it anymore. What else is there? It works, but I don't want to use it. Like, hey, I got these glasses. These work.
It's a little
you know what?
uncomfortable.
I'm tired of wearing glasses. Don't you got? So yeah,
Right.
I'm going to get contacts. And then you wear contacts for 2, 3, 4, 5 years, and then you're like, when I go skiing, they fall out of my eye in the water, and then I go to Vegas, they get all dry at night. I'm laid up at late, they burn and itch. What do you have? Oh, we have LASIK, and so then you go get your LASIK eye surgery. Do you see my point? So people pick their treatments based on where they are in the treatment kind of algorithm, what they've tried already, what their beliefs are, how much money they have. If $2,500 is not a big deal to you, then they'll try an oral appliance. I mean, if I had both treatments right here, I said they're both free, pick one, 100% are going to pick the oral appliance to try. Not that it will work or don't work, excuse me, but if they're all free, people would just try it, because what are they going to lose? What are you going to lose by trying? Nothing. But
insurance does not cover that, right?
They do. They kind of, yes. They contribute. How about that?
Okay.
So there's a contribution, but even with the contribution, there's still an out-of-pocket. So I have patients come in who don't care. Like, I want it, give it to me. So I dispense them all the time. But I just know for sure if I'm having a conversation, I won't say 100%. It's not 100%. But because there are some people who don't like stuff in their mouth. They drool or it gags them, things. So nothing's ever 100%. But the vast majority of patients, if you gave them a night guard, a little piece of plastic this big, in the machine with the mask and all that, and you said, pick one, they're both the same price or they're both free. Which one would you like to try first? I can promise you the majority are going to pick the piece of plastic, okay? Doesn't mean they're going to end up there. They may come back later and switch to CPAP. I just had to put my friend on CPAP. He's younger than me. He's in his 40s, had a stroke in his 40s.
Oh.
And he's paralyzed. Well, he was completely paralyzed on his left side. And now, thank goodness, he can walk. He's got shoulder drop. He's got foot drop.
Was he overweight?
What's that?
Was he overweight?
No, he's a little guy. But he had a stroke like 4 or 5 years ago. It was like right when COVID started. So, and he has lupus, and so he takes chronic steroids and some. He's got other reasons why he could have had a stroke early in life. But he's been tired for a long time. He blames it on the stroke, and then of course he takes, it's my testosterone. So now he's, getting the pellets and all the whatever shots. And then it was, he wanted more steroid, prednisone he thought it was his lupus. So he's taking more. He's looking at all these reasons why he feels like crap, tired during the day. He wants stimulants because, he's not motivated during the day. And so I finally tell him, dude, you got to get a sleep study. You've had a stroke. pretty much if you had a stroke, so 9 out of 10 chance you have sleep apnea. It just works out that way. It's a really high risk factor. And sure enough, he's got sleep apnea. I just gave him his device yesterday to try. 2 days ago. No, yesterday. So
no feedback.
If you looked at him, you would not think this guy has sleep apnea. He works out, he's buff, little neck. But because sleep apnea can also just be an anatomic problem. It's an anatomy issue, right? A lot of guys have beards or mustaches, small chins, they have small chin, small lower jaw. They don't have any room down here, so they have sleep apnea. A lot of Asians have sleep apnea.
Right.
They're not overweight.
Think of that.
Because it's a space problem. It's a collapse problem, but it's also a space problem, And so it's not just guys with 20-inch necks walking around with sleep apnea. They have it too, and not every guy with 20-inch necks, by the way, neck has sleep apnea, but a lot of them do. So a lot of Texas football players, have sleep apnea.
Would it surprise you if I told you I cannot sleep without it?
It wouldn't surprise. It doesn't. No, I hear it all the time. Yeah. It's not that bad to sleep with it. People get what's called addicted to it. I have some patients who lost a bunch of weight, and weight was one of the reasons they had sleep apnea, and they still use their CPAP machine. They don't even have sleep apnea.
Wow.
They still want to wear it because they just like the air. I try to
Yeah,
give people the right mentality when, I feel bad. I feel like when you diagnose someone with sleep apnea, you diagnose with cancer, I just see this look like, oh shit, I got sleep apnea, and I'm going to have to sleep this effing machine. And I try to play it down. I mean, I'm like, you're not having sex, with their CPAP mask on, you're not walking around the Galleria with your CPAP mask on. Have your sex and then then put your CPAP machine on. I mean, I try to, at least you're unconscious, when you're wearing it.
yes, right.
But it's not the only treatment. It's just the one that we know works all the time for most people, but that doesn't mean it works for everybody. Do you know what I mean?
Do you laugh at the commercials you see, or these online
Yeah.
ads? Quit snoring. They put a little piece of tape on your
Yeah,
nose.
right. Yeah.
You just laugh at that?
No, there's a whole industry on desperation is what it is.
Yeah.
It's just like back pain or other shit. There's like no good treatment, so any treatment's better than no treatment. So then and then they're dying, so they're just throwing money. And if you make it cheap enough, people will throw money at it. That's what I mean. If the appliance was $50, people would throw money at that. But if it's $2,000, people can throw any money at that. So, but one works and one doesn't. So yeah, there's like they had this thing called ProVent. It was like these one-way valve, not things you put in your nostrils. You tape them in your nose, and then as you exhaled, it would create positive expiratory pressure. It's called PEEP. It's on if it's a part of, if you're a respiratory therapist, you'll know it's PEEP is part of ventilator settings. But anyway, and the idea was that as you exhaled, it would create back pressure and then dilate your airway just long enough so when you took your inhale, you still have some room.
So on a CPAP machine, there's different settings.
Yeah.
There's all kind of numbers, pressure. How often do you have your patients come back to test to see if you've got to change the numbers or the settings?
The only setting that's treating you is the pressure of the air in the system. So that pressure is measured in centimeters of water, and it ranges from 4 to 20 for most people, most machines. And most people, as you'd imagine, need, kind of in the middle, like 10 centimeters of air pressure. And you can't look at somebody like, oh, it's not like a shirt. Oh, you need an extra large, because you're big. It's not like that. You could be your size and need 7 centimeters. And I could have someone next to you who's half your size and need 10 centimeters. Okay. Because again, it's an anatomy issue, not just a how big you are issue. Okay. And so the only setting that's actually therapeutic is the pressure. And that's why it's a prescription. But there are a lot of comfort settings that are patient controllable, and that's for comfort, like ramping the pressure from low to high before you fall asleep, humidification, stuff like that. But the force you need is a prescription. Like it's like if you're going to open a door, right? At some point, you can push on the door until you give that door enough force, it's not going to open. After that, it opens. So any force below that force is worthless because it's already opening, until you apply that much force. So anyway, the follow-up is basically really, it's either you have a significant medical event like a heart attack or stroke, you should get reevaluated, or you have a significant weight change in either direction, higher or lower, like 15, 10, 20%, you should get reevaluated.
Here's a new question I've never had anybody ask before. This is from the Heights. Gerald, he said, I am on a CPAP machine. I'm supposed to put water in it at night, but I never do because I'm lazy. Does that make a difference?
No.
Okay.
No, it's a comfort feature. Humidification is a comfort feature. So, yeah, I mean, if
it's
you
a
like
humidifier or something, right?
What's that?
Is it a humidifier?
It's basically a stove next to your CPAP. I mean, it's a stove. If you take out Steve, check it out. Take out your container for your water. The bottom is a metal.
Yes.
And it's a warming plate. It's a stove. So the hotter the stove, the warmer the water, the faster it evaporates, the cooler the stove, the cooler the water, the slower it evaporates. If you just spill water on the floor, eventually it's going to evaporate. If you blow a fan over the water on the floor, it's going to evaporate faster. If you use a hair dryer on the water on the floor, it's going to evaporate even faster. So that's how you control how much water vapor gets into the air. Some people like cool air. Some people like warm air. Some people like a cold bed. Some people like a hot bed. Some people like a soft bed. Some people like a hard bed. I mean, it's just patient preference. Yeah.
Do your patients, this is kind of a personal question I have, what percent of your patients want the nasal versus the mask?
Yeah.
I couldn't stand the mask.
Yeah. You
I
mean
had to
full
go
face?
the nasal.
Yeah. So masks are like shoes, you know. You like sandals. I hate sandals. You like the one little thing between your toes. I can't stand that, you know. I got to have the strap behind my heel. There isn't a right shoe. If you like it, that's a good mask. You know, if I like it, it's good for me. What's good for me may not be good for you. So I will tell you one important thing if you're on CPAP. There's a lot of people get their equipment from these, you know, third-party vendors, and they're like, oh, do you mouth breathe at night? Like, oh yeah, well, you need a full face because you mouth breathe. And what cracks me up is that every single patient who suffers from sleep apnea, when they're not treated, wakes up with a dry mouth. Every single patient who has untreated sleep apnea mouth breathes, because when you can't breathe and then you have your arousal to breathe, the biggest hole in your head is your mouth. So you open your mouth to get the air you need as fast as you can. Just like if we were in a pool together and I was holding you underwater until felt like you're gonna, you know, drown, and I let you go. When you shoot out of that water, you're gonna breathe through your nose or your mouth. Steve?
I hear you. Oh, I believe that in my mouth.
No, but I'm saying if I hold you underwater for a minute and a half and you think you're gonna die of freaking drowning, and I let you go and you shoot out of the water, are you gonna come out of the water with your mouth wide open, or are you gonna breathe through your nose when you come out of the water? You're gonna breathe through your mouth.
Yeah.
You're gonna gasp for air through your mouth.
That's right.
Of course you are, because it's the biggest hole. It doesn't mean you suffer from nasal obstruction. It means that you need freaking air right now. So a lot of people get full face masks when they don't need it, but it's just comfort. So mammals are designed to breathe through their nose. Okay. We had a show before about the nose. The nose has turbinates, and the turbinates are what allow our nose to humidify the air. So you want to push the air through your nose, because that's how you want to pull the air into your body, is through your nose. So it's usually more comfortable to use a nasal mask, but sometimes, especially when the pressures are higher, you can't keep your mouth shut, and so you have to use a full face, which just means you're pushing the air in the nose and mouth at the same time.
This is from Roman. He wants to know, he said, I read about if you snore, there's a surgery out there. Do you do that surgery?
Wow, that's vague.
What's that?
That's vague. I read about this. There's not the surgery for snoring. Okay, it's a snoring evaluation is honestly very similar to a sleep apnea evaluation, because it's an airway resistance problem. So you got to solve the airway resistance problem to solve the snoring problem. The difference is snoring is not considered a medical problem. It's considered a cosmetic problem. So if you snore because of nasal problems, well, the good news is breathing through your nose properly is considered a medical problem, and those procedures are covered under insurance. But if I said I want to do nasal surgery for Mr. Smith because he snores, your insurance would deny that, because they don't treat snoring. But if I say I need to do nasal surgery on Mr. Smith because Mr. Smith can't breathe through his nose, they'll cover that, because breathing through your nose is considered a medical problem. I should say not being able to breathe through your nose. Do you follow me?
Yes.
But that question of snoring, that's a multitude of issues. It's not one thing. If I could invent that, Steve, I won't even be on your show, because I'll be in Tahiti on the beach with a Mai Tai, and I won't be sitting here taking care of patients every day. I'll tell you right now. Yeah.
That's right. When a patient comes to see you, what is the first test that you give them? Is it the sleep test that they do
You mean
over
if a
the
patient comes to see me for concerns of sleep apnea?
Yes.
Outside of the examination, what's the first test I do?
Yes.
Well, it's a home sleep test.
You know, it's amazing. How come they didn't figure that out a long time ago that you could take that sleep test at home instead of going to a separate clinic?
Well, I mean, you got to remember, sleep is pretty young, Steve. I mean, sleep apnea wasn't even really understood until the like 70s. I mean, we didn't even stage sleep until the 50s. We didn't even know that we had REM and non-REM. And people that suffer from severe sleep apnea in the very early days of sleep specialty is a young specialty in and of itself compared to the other specialties. But all those patients were thought to have had narcolepsy. Okay. They didn't, even the sleep doctors didn't know they had sleep apnea. They thought they were suffering from narcolepsy. And it was because the very early sleep tests in the United States, they weren't testing airflow. They were just looking at your brain because they thought sleep is a brain thing.
Right.
So they were just looking at sleep and seeing all this messed up sleep stuff going on in the brain. And so they didn't realize people were like, couldn't breathe. And then this sleep guy from France came over and joined Stanford. Stanford was the narcolepsy kind of capital of the state of the United States. They were considered the experts. In France, they were doing airflow channels with their EEG channels. So they started doing airflow channels here, and that's how they started finding all the sleep apnea. And of course, the first patients they found on were the ones that were like the stereotypical sleep patient, like the super obese guy, you know. So those are the first patients that were diagnosed. And then it just took a long time for that to transition to a more mainstream, you know, that a lot of people have it, not just overweight people, and this and that. A lot of women have it, you know. A lot of people have sleep apnea. I'm telling you, it's a lot. It's like I have job security. Okay, there's not enough of me to go around.
If a person, we're almost out of time, but if a person has high blood pressure,
Yeah.
should they come in and make an appointment to see you?
Well, if you only have if you have one drug, like you're on one medicine to treat your blood pressure and you don't snore and you don't have any symptoms, no. But if you snore and have high blood pressure, I would get screened. I mean, the question is it worth a $150 test to find out? It's a $150 test. I mean, we're not talking. I mean, why are we debating? It's not like thousands of dollars to find out. It's a $150. It's Steve. It isn't the $150. It's they don't want to know. You're kind of backwards. They don't want to know they have sleep apnea because then they have to have this damn conversation we're having, which is, what the hell do I do about it now that I got this sleep apnea? Do you know what I mean? So if you're not really feeling bad or you're not scared about it, what's your motivation to treat it anyway? It's like any other condition that, you know, it's like kills you slowly. Most people don't treat it until they really have to. Like, yeah, doc, I know, I got to quit smoking. I get cancer and COPD.
Right.
And then when I'm taking their voice box out at, you know, unfortunately at 65, got their tongue cancer. Now they're all, you know, sure, they're all full of regrets. Oh, I should. And then the irony is then they stop. Like, well, after we take out your voice box, now you're going to stop smoking. But you know how it is, young and dumb, and you know how the saying goes. So people will invest in that workup when they feel like they need it, you know, and more people need it than know they need it. But eventually it gets to the point where they get tired of being tired. They get tired of whatever it is, and then they'll go get it taken care of. Until they get to that point, you know, it's like it's just like it's in the back of their mind as a to-do, you know.
Yeah, you tell me about the people that maybe were for a while and they stop. I got to tell you, when you have friends of when you fall asleep in a class, which was so embarrassing, and you
Yeah.
snored, and you almost fall asleep at the wheel. I don't care how I'm going to wear that sucker every night because I,
I
think about
think
that.
I told you before, I was coming back from Vegas with my family, last year, and this guy one row in front of me in the aisle seat, I was in the window seat. I mean, the guy, I'm literally watching him die in the chair. It was so bad. It was like I am watching the sleep test real time. In the chair, he's like,
Wow.
and then he'd get up and look around, his eyes are all glazing, and he, like literally just like classic. And the thing is, he spoke Spanish, and unfortunately, in Houston, I should know how to speak Spanish. So I was using that Translate app on the iPhone, I'm like, dude, you got sleep apnea. He's like, no, I just partied too hard in Vegas. I'm like, no, dude, you're dying of sleep apnea. And I actually got his email address and sent him a link to a CPAP machine. And, he actually bought one. He sent me a receipt back.
Oh, no kidding.
He lived in Mexico. So I saved one life. See, I do save lives. There's one guy's life I saved. Yeah.
So tell people how they can reach your office.
Actually, the best way, probably fastest for someone, is our website, because we have a contact us form, sugarlandent.com. But we do have people that take phone calls. So I have two great staff, Elizabeth and Tim. They're ex-military, great. Patients love them, very respectful, humble. Actually, Tim was my patient before he worked with me, so it's nice. And then call us at 281-556-1102.
I can't tell you how much I enjoy doing this show. You'll be back again with us next month. We also run the show again next week. Dr. Ludwig, I am so glad we have you.
Thank you.
Thanks so much.
Have
a good week. That's Dr. James Ludwig, Sugarland ENT. Folks, I'm telling you, it changed my life. That's it for us today. We'll be back in with you next week with more Ask the Experts.
Thanks for tuning in today to the Ask the Experts show on W4CY Radio and Talk4 TV. Tune in next week and every week to hear more from our experts on personal injury, insurance, air condition repairs, estate planning, Medicare, and many other topics in the areas of legal, health, financial, and home improvement. See you next week.